Good afternoon and welcome to today's webinar sponsored by BD, Vascular Access in the midst of COVID-19. I'm Judy Thompson. I'm the Director of Education at the Association for Vascular Access, and we welcome you to today's program. Our speaker today is John Bell, and I do want to send a special thanks and shout out to BD for sponsoring today's webinar. We couldn't do these without you, so we so much appreciate our sponsors. BD, thank you. John's bio has been up here a few times. I'm going to tell you a little bit more about him in a second, but he has a lot of experience in vascular access and in the emergency department. So you read his bio a little bit. Now I get to tell you a little bit more about him. John lives on the Maine coast near Bar Harbor. He loves to sail, kayak, and hike. John and his wife have 2 daughters, and the youngest just graduated from college. Congratulations, John. And he's happy to announce that he didn't have to sell a kidney for that one. John fell in love with vascular access as a way of improving patient care and decreasing pain and anxiety by avoiding unnecessary sticks. And with that, I'm going to turn the presentation over to John and take it away.
All right. Well, welcome everybody. Yep, as Judy said, I'm coming to you from beautiful Maine. It's whopping 78 degrees here. Beautiful, beautiful Maine day. I hope nobody's too hot down south while we're enjoying things up here. But we're here today to talk about vascular access in the midst of COVID-19, and like we've been talking about anything else much for the last 3 or 4 months. Let me quickly run through my disclosures. I do work as an educational consultant for multiple companies. I'm also a director at large for the Association for Vascular Access, who's putting this webinar on. I will not be discussing any off-label or investigational use of any kind of products or procedures. We're just going to talk about the science. Our learning objectives today: we want to understand the way in which crisis affects our perceptions of common procedures. So again, as we go into times of crisis, it changes the way our brains work about things, and that gives us opportunities, and we're going to talk about that. We want to identify areas of vascular access improvement that are highlighted by this crisis, and we want to describe ways to improve vascular access in your organization. And so I'm hoping that there's somebody here that listens to this and goes, oh, we're doing all of that, and we've got this thing down, and we've got the tiger by the tail. I hope you're out there. I'm hoping that the majority of people here, that we're going to look around us and say, oh yeah, we could do this better, we could do that better, and go back and talk about how we do that. Because ultimately what we want to do is not just get education for the sake of education, but we want to compose a plan to implement change in our organization, specifically around vascular access. I found this quote, thought it was a really good way to start for us today. We all face adversity from time to time, but some of us are able to flourish when things get difficult, while others seem to struggle getting out of bed in the morning. And certainly, I think probably many of us have been in that place throughout this time at some time or another. But successful people have found a way to jump hurdles and navigate around roadblocks that would stop others completely, right? That's the difference between really successful people and average people. They get up and they find a way to go out and to do that extra basketball practice to get really good where you can go play in the NBA, or to swing that golf club, or again, I'm a sailor, so to learn to sail the boat better so that you can sail competitively. So when it comes to medicine and taking care of patients, the reason that there are vascular access specialists is that we went out at some point in time and we started looking for ways to navigate around roadblocks and become more successful and learn new skills that would help us help our patients even better. So that's what we want to talk about today. What are those roadblocks and how can we navigate around them? So pandemic, this pandemic is something like we haven't seen in 100 years, right? And there's no question about that. It's out there. We haven't seen anything this wide-ranging that affected the whole world since the 1918 to 1920 influenza pandemic. So what are some of the challenges, right? We have patients on increased precautions. We always have patients on droplet precautions and contact precautions all the time in the hospital, but now all of a sudden we were faced with, we're going to have tons and tons, and basically everybody needs to be on increased precautions. We went from using masks on certain patients to having masks on all the time, every day. There's new challenges with infection prevention. The fact that as a healthcare worker, you could be asymptomatic and yet be a carrier for the disease and possibly pass it off to your patients. So how do we deal with that? Increased number of critical patients. And we realized very early on, we were talking about flattening the curve, that there was a potential to have more patients needing ICU beds than there were ICU beds existent in the country as a whole. And interestingly enough, this is something that some people have been saying this for years and years and years, and we've kind of ignored it. But it came to pass for us this year, and we had to think about, can we make extra ICU beds? Can we get extra ventilators? All that stuff. So that was a big challenge, right? Increased patient loads because of staff being sick, staff being unable to work, and things like that. Increased vascular access therapy. Patients that needed, critical patients that were very critical, that needed more lines than maybe the normal caseload in an ICU would need. We were facing that early on. Increased bed capacity, again, kind of same thing. Staff shortages, critical care capacity, and then the need for equipment and training. And then the last big one was PPE and other supply shortages. Do we have enough masks? Do we have enough gloves? Do we have enough gowns? And that was a huge challenge that we're going to continue talking about for a long time, because part of that challenge was globalization and international supply. And when that international supply got disrupted, that created a huge shortage and a huge challenge. So those are some of the challenges that come to mind that we've been all facing and talking about for the last couple months that were brought on by the pandemic. So how does that affect vascular access? Well, let's take a quick poll here, Judy.
During the pandemic, did you see, and select the following: more patients, same number of patients, or less patients? And let's see what they said. So we have 62%, John, had less patients, 22 more, and about 16% came in at the same number of patients.
Interesting. Well, thank you. Yeah, and certainly, of course, going into this, we were talking about that we're all going to be crazy and we're all going to be busy. And then in my area in Maine, southern Maine had a lot of cases, but up in northern Maine, we didn't have as many cases, and we had people getting furloughed because the hospitals were emptied and they didn't have as many patients as normal. So that was its own kind of problem with the pandemic that we're not going to really talk about. But what happens? What are the consequences of dealing with a pandemic? Well, there's a couple of things. Have non-compliance with standard operating procedures, standards of practice. Even within hospital policy, there were things in policy that we couldn't follow anymore, and because we didn't have the means to do that, or the time to do it, or something. A modification of hospital policy procedure, gaps in vascular access process. So what happens when those kind of things come on? Well, if we don't follow the standards of practice, they're the standards because that's how we control complications. So now we can have increased complications. We have an increase in staff exposure. If people are don't have the PPE they need, or they're having to interact with patients in a different way than normal, they might be more likely to be exposed to different things that are dangerous to them. Treatment delays, right? If we're not doing things efficiently and well, we could have a delay in treatment, which in a critical patient could be very, very bad. Increased sticks for peripheral IVs, for central lines. Again, one of the things I heard that we'll talk about a little bit more later is, people all of a sudden wearing double gloves that they have never worn double gloves before. And that can really change how things feel in your hand and your ability to do even common tasks that you're proficient at. Patient discomfort, of course, more sticks. Patients are already uncomfortable when they're sick. Increased costs. Again, every time we have to start a new IV, that's an increased cost, $25 to $45, depending on which studies and kind of how you break it down. But increased cost at a time when there's already a strain on the healthcare system. And then along with that, increase in supply usage, meaning more stuff moving around the hospital, more waste stream, all of that. And then the big one, which there was a webinar just last week about, clinician stress. And again, we don't spend a lot of time talking about this, but what does it do to our staff? And I think we will spend a lot of time talking about this in the next few years. What happens when we take people and we ask them to work in a mask for 12 or 14 hours a day, constantly wearing PPE, constantly in a room dealing with dying patients, and what does that do? And then in turn, what does that stress do for my ability to work within the policy and procedure of the hospital, to work within the standards of practice? So these are all the consequences that come from the stress of the pandemic. So what does this mean for us? What are we here to talk about? What we have always done inefficiently, we need to recognize and make more efficient. So we get away with all kinds of inefficiencies all the time. I work in the OR. I've worked in the OR for 13 or 14 years. So we can take all the time in the world in between cases to turn over cases, and it makes cases run long, and it slows things down and it's inefficient. But we can get away with that when there's not emergencies. But when there's emergencies, that kind of inefficiency is highlighted, and it gives us the opportunity to recognize them, name them as being inefficient, and then figure out ways to stop doing those inefficient things and doing efficient things, make them more efficient. We need, this brings on a demand for greater first stick proficiency. If every minute I spend at the bedside with a patient who's possibly could make me deathly sick, it just heightens the need for me to get that line in the first time, and not to be back in there every 6 hours starting a new line, or every day starting a new line. It's critical to limit unnecessary procedures and patient interactions. So that kind of goes along with the previous point that I was making. It's imperative to limit treatment delays and waste in an overburdened health system. Again, if we don't have a good line and we have to wait for somebody to come and put in a better line, then that delay could be disadvantageous to that patient. And meanwhile, it's stressful to the nurse at the bedside. It's stressful to the doctors at the bedside who are trying to oversee that care. So we need to limit those delays and waste. As soon as again, this is one of those things when everything's going hunky-dory, we can be kind of loosey-goosey and wasting stuff. And I mean, nobody's ever going to say, oh, it's okay to waste supplies, but it happens. We've all seen it. But when you're thinking about, we have a limited number of gowns and masks and bouffant caps and I can't go through 5 of them in one procedure because maybe 2 days from now when I need to do another line, I'm not going to have that PPE that I need for the patient's sake. And so we need to limit that. What do we know? We know right off the bat, vascular access has not been treated seriously. Well, that's a pretty serious accusation there, John. Really? How do you say that we're not treating it seriously? Well, the literature says that up to 50% of peripheral IVs fail before we're done using them. So in 2020, with all of our high-tech healthcare system, we are at the best case scenario, we're 50% effective at putting in IVs that will last as long as the patient needs it to last. Now, if you're playing baseball, batting 500 is fabulous, right? Everybody would love to bat 500, but that's about the only place where hitting 50% of the time is really acceptable. And when we're talking about patients and their treatment and their pain and their anxiety, we really aren't talking about it seriously if we're allowing this to happen. Again, there's ways that we can fix that. We'll talk about that. Vascular access hasn't been treated scientifically because many patients are not given the lines that the evidence says they should get. We see this in social media all the time. People are saying, oh, they're asking me to put in a different vascular access device because they want to pull this other vascular access device. Well, why do they want to pull it? Well, they want to pull it because they're afraid they're going to get drugged. That's not what the evidence says. We have to treat it scientifically. We have people say, well, I feel that this would be better. Okay, well, the science doesn't care what you feel. The science is what it is, and we have to do what the science says is the best thing for the patient. So we have to have those conversations. We have to have education. And then a very common thing that's happening is there is education, and there's the vascular access team knows that it's not appropriate for this patient to have this line, but somebody else says, well, I want you to do it. And the vascular access staff is not empowered to say, no, that's not what this patient needs. And so that's a big problem. Specialists can address inefficiencies. We know this, there's plenty of literature out there. The whole reason we have specialists is we know that people who do things more and more and more, and they do it all the time, they get better at it, and they know the nuances of it. And there's always going to be room in this world. There's always going to be room, and in the American system, for generalist physicians, generalist surgeons, generalist nurses, generalist respiratory therapists, everything. But there's also a lot of room for specialists, and we need to understand where those lines fall and why they fall there. Specialists can address inefficiencies, and the scary thing is the number of places where they are still talking about cutting back on specialty services with the idea that that will somehow improve the bottom line without understanding what that means for patients and patient care. So why do PIVs fail? We said that the problem is that 50% of them fail. I think probably one of the number one and number two things are right here: poor device selection. We just don't have the right device in the patient. Most commonly, that is, we've got too large a device. Again, as an ER nurse, we pride ourselves on hammering large bore catheters into everybody, and I used to do that too, and I was very proud of my ability to do that. But if we put an 18 gauge catheter in a 17 gauge vein and we take up 95% of that vein, there's not good blood flow around it. It's going to be highly likely it's going to clot off. It's going to be close to the walls. It's going to set off phlebitis, and it's going to fail. So that's a poor device selection. Sometimes people start using ultrasound and they don't have the right devices and they're going for deep veins with shorter needles, and those devices are going to fail. Poor site selection, most commonly, and I love this little picture that we have here, is putting IVs into areas of flexion, most commonly the antecubital space. And again, that thing's moving around in there. It's causing irritation inside the vein. It's causing clotting factors to set off. And they often work their way back out and kind of ratchet out. And so that causes a problem. Poor insertion. Again, if we do a highly traumatic insertion, we're going to set off those inflammatory factors. We're going to set off those clotting factors, and that's going to cause them to fail. Poor securement. If it's not secured down and it's wiggling around and it's getting tugged on and it gets pulled out or it gets pulled halfway out and pushed back in, those are all things that cause failure. Poor maintenance. Failure to maintain the dressing. We're going to talk about that. Failure to make sure that we're cleaning this thing well so that we're not introducing any infection in it. So when we don't do these things right, what do we get? We get dislodgements, we get infections, we get phlebitis, we get infiltrations and extravasations, and we get occlusions. And all of those things cause failure. All right, Judy, we got another poll here.
In your facility, are PIVs placed in appropriate sites, removed when not used, and dressed in a clean, dry, and intact manner? Usually 43%, occasionally 43%, and rarely 14%.
Okay, well, that's a little better than I thought. I would have kind of thought that maybe it was, you know, 20, 50, 30 or something like that. But anyway, so good. It's good to hear that. And that's that means we're moving somewhere, and that's good. So we always have places we can improve. So what can we do? We've got to go back to the basics, right? We just got to go back to the basics of the standards of practice and the guidelines, and we have to give the patients what they need, and they really deserve that, right? We've talked a lot in this time too about justice, and one area of justice is that the patient gets what they need. That's just. If they get something else other than what they need, that if they get something that's convenient for me, that's not justice for them. So we can improve by improving vascular access assessment, improve insertion, and improve care and maintenance, right? None of this is rocket science. This is just going back to the basics of improving these things, and we'll get better vascular access for the COVID-19 patient, for all of our patients, and for the next pandemic that comes down the pipe. So how do we improve vascular access assessment? What are we talking about here? Well, if you've heard me talk before, I've been on this stump for a couple of years now, but we need, come on, there we go. We need to assess using a comprehensive objective tool to determine the most appropriate access for the patient's plan of care. Again, assessment, everybody assesses their patients, but not everybody assesses well. And one of my favorite studies that came out even just last year or maybe late 2018 was a study that said more experienced nurses do better assessment than less experienced nurses. And we hardly would even need a study to say that. That was actually a study about vascular access assessment. And again, those of us who've been doing vascular access for a long time, even as generalists, we go in and we look at a patient and we can glance at them and know that they're going to be difficult or not. But not all of our colleagues have that same ability. I like the term gestalt, the ability to know without having to sit down and think about, it's not a checklist. Oh, this, they're going to be difficult, but we just know. We have that gestalt, but not everybody knows that. So by having a comprehensive objective tool, then we can help everybody assess at a higher level. So we need to assess for what the patient needs. It doesn't do us any good to put a central line in somebody just in case if they don't need a central line. It doesn't do us any good to put a peripheral IV in somebody if they need a central line. We need to assess and give them what they actually need for their plan of care. Now, again, I understand this is never going to be completely perfect because we're making educated guesses about where the treatment's going and what's going to happen. But we need to do our best and not just be making knee-jerk actions. Assess for accessible vasculature. Again, the assessment can't just be, oh, they need a peripheral IV, so I'm going to go in and stick them 8 times until we get one. If the objective tool will help us to recognize if they're going to be difficult so that we can bring to bear other avenues to get them what they need. And then it's important not just, there are several tools out there that say, okay, this is a difficult patient. We're going to talk about that a little bit more here. But as you look at these tools, the weakness of some of them, they're very good tools and they've been validated and stuff. But if they don't tell you what to do after you identify the difficult patient, it's kind of worthless. And sometimes when I have this conversation with people, they say, why should I use a tool? Because at the end of the day, whether they're easy or whether they're hard, the only thing I can do is go in and just give it the old college try. So the tool needs to direct you to a plan that's a real plan that says, if they're more difficult, we have this in mind that we can do that. So what do we need to get them access? Peripheral access. Will a basic PIV work, or do we need an advanced PIV? Now, let me just quickly talk to this. This terminology hasn't been used a lot, and so let me just define my terms. To me, a basic PIV is something that I could send a student in and say, go in and stick this patient. It's just very basic. They're going to put a tourniquet on. They're going to find the vein. They're going to stick that vein, and if they've got any skill at all, they've got a pretty decent chance of getting it. Anything beyond that, anything that we start using extra skills and adjuncts, really, to my mind, becomes an advanced PIV, and all the way up to using ultrasound and those kind of guidance things. Central venous catheters, again, we have 2 broad categories: peripherally inserted, centrally inserted central venous catheters. Again, what is most appropriate and how do we get it in this patient? Sometimes we have patients that are very appropriate to have a peripherally inserted central catheter, but they don't have the veins in place. They don't have big enough veins in their arms to do that. And so now we need to be able to address that and adapt the plan and get them what they need, which in that case would be a centrally inserted catheter. All right, we have another poll here.
So my facility has a way to identify DIVA patients before multiple failed attempts and direct a specialist to place a device. 53% do not have a way to identify. So
well, I'm excited.
Or no, or kind of something.
Yeah, it's good that that's that high. And again, this is something that's relatively new. And I'll talk about that a little bit more. We're going to go over the tool that I've used, but it is a newer thing, and I hope that that there's not going to be anything to talk about two years from now, because it's going to be so common that everybody's using it. So when we talk about assessment, let's talk. That was kind of generally what we can do with assessment. Let's talk about this pandemic and what do we need. So of course, the first big question is, does this patient need central access, or can they be treated with peripheral access? And the fantastic thing about a pandemic is this is the novel coronavirus is what they call it, right? So we went into this thing not knowing a whole lot about what the best treatments were. Early on, we were using some antibiotics that now we don't think are really that helpful. But going in, we need to ask these questions. Are we using multiple antibiotics? Are they compatible? Do they need to be central? There's some antibiotics that are a little bit gray, right? We can do them for a week, maybe peripherally, but if we're going to be going for 3 weeks, maybe we need something a little bit better for that patient, and so that we don't give them 6 IVs over the next 3 weeks and use up all their vessels. They may need a longer length of time. Of course, whenever we're dealing with really, really sick patients, we have to worry about whether or not they will decompensate. And again, this is an area of controversy that we're still spending a lot of time talking about. But pressors, the evidence says that pressors should not be given in peripheral access. And I know a lot of places do it on a short term. The problem is, what is short term? It's one thing to start a drip of some pressors on a patient and then immediately work to get central access and move that over. It's a whole nother thing to say, let's start them on pressors, and if they don't get better in 4 hours, then we'll talk about a central line. But that's really the way a lot of facilities work. So that would be part of our assessment. And now that we're 3.5 months in, we know a lot more about how these patients respond, how they decompensate. So it was good to hear that early on, a lot of places were very proactively going after good central access on these patients so that when they decompensated, they were ready. And again, an evidence-based practice decision should be made for each patient. This is no time for cardboard cutouts and simple recipes, but we need to really assess each patient and decide collaboratively within the care team, what is the best thing for this patient? What do we think that they're going to need, and how are we going to get there? And what are we going to do if the plan changes? And so everybody has their ducks in a row. What kind of medical management will they need? This looks, yes. So one of the things that has come up and is now been talked about quite a bit. When I first started putting this presentation together, I'd never heard of remdesivir, but now we've talked about it a lot. There's been a lot of articles. The biggest thing with that is remdesivir has a fairly high rate of phlebitis, and it also has some hepatic issues, which means if patients are on it, they might end up needing dialysis. So that's really going to change things. If it's going to destroy, if we have limited peripheral veins and it's going to burn them up, and the patient might already have some renal insufficiency, we really need to be talking about central access. Again, dialysis access can be very challenging. It's a large bore catheter. It needs to be placed well, needs to be secured well. We need to make sure that that thing stays in, because that becomes even more of a lifeline. If we lose a central line, we can put another central line in, and maybe we can keep the patient stable while we do that. But if we lose a dialysis catheter in the middle of dialysis, that's catastrophic. If we lose it and the patient needs dialysis right now, and it takes us an hour and a half to get a new dialysis catheter in, that's pretty bad. What kind of airway management will be needed? Again, as we're working around the neck with central lines, we have to factor those things in. If the patient is going to be intubated, and we get a central line that's up here, and it's going to be right where we need to secure the airway, not a great thing. And then of course, positioning. So very early on, we recognized that many of these patients needed to be pronated um, to effectively manage their lungs and the ability to oxygenate the patient. And that pronation led to some serious difficulties. If the patient's face down, it's harder for me to assess the central line and make sure that it's there, make sure that the dressing's intact, make sure that nothing's pulling on it, make sure that it's not kinked. And then patients don't just pronate for 3 weeks, right? They've got to be moved in and out of these positions. And every time we move somebody, that runs the risk that we can pull lines out, displace those lines. So again, that's something that we need to assess that's kind of specific to COVID. So poll question about pronation.
Absolutely. In the last 3 months, have you had to place a line in a pronated patient? Okay, results are in. 83% have not.
Okay, good. Well, that's good, because I think that means that there was some planning that went on. And so those lines went in, and they went in well, and they were secured before the patient needed to be pronated. So that's good. Of course, the bad thing is if the patient's prone and they need to be prone for the next 6 hours and you've lost the line, maybe it got pulled out when they were pronated and now you've got to roll with it. Those are challenging. But again, if we plan, we should be able to avoid that. So difficult IV access patients, as Judy just said, that's what DIVA stands for. And when we talk about COVID, they become a special concern. Why? Because if this person's going to be in the hospital for a long time and they're going to be very sick, if we blow 5 veins, those veins aren't going to heal maybe before the patient goes home. They may need multiple devices. So every time we destroy a vein, we lose the opportunity to go back there for another device if the patient needs more than what they've already got in. And then, as we alluded to in the introduction, if we identify these people early and we get that treatment going, we're going to save time and resources. We're going to reduce delays. We're going to reduce the risks to the patient, the risks to the providers, and make everything go better. So that's why we need to talk about doing really good assessment and getting the patient what they need. Oh man, I am running short on time, so I'm going to try to move a little bit faster here. We may skip over some of these polls, Judy. I really don't know how I got this far behind. So assessment tools, there's a couple of them available. Throw them up there. If you haven't heard of any of these, you can write those initials down real quick. But they enable objective assessment. They empower staff to recognize and get the patient without failed attempts. One of the most shocking things to me is the idea that I have to fail a couple of times before I can get somebody else, and they have to fail a couple of times before they can get somebody else. That's not good patient care, because what we want is first-time success, and these tools enhance that. It enforces vessel health and preservation, right? People don't come from the robot factory, and they have different veins, and they have a limited supply of veins. And if we use those veins up, and if we treat everybody like they should have a great big huge AC, and we stick around and we poke around in there and they don't have a big AC, that's not preserving their vessels, and it's not healthy for them. So what I want to quickly talk about, if you've never seen any of these tools, I'm going to quickly go through the C-DIVA, the Comprehensive Difficult IV Access Tool, so that you can understand what we're talking about, how it works. I'm going to move pretty quick through this, and but I worked on this tool with some colleagues, and we derived it from the A-DIVA tool, which was published by Van Loon in 2016. It's simple to learn, it's easy to use, and it helps staff to recognize difficult patients, and most importantly, it tells them what to do once they've identified those patients. So here's how it works. It's got 4 components. This is so simple. First of all, visual appearance. Can you see some veins? If they've got many visible veins, they get 0 points. Few, they get 1 point. No visible veins, they get 2 points. Do they have palpable veins? Again, 0, 1, 2. History. They have no history. They have some history, something like they say, oh, they sometimes have trouble. And then severe history is when they start telling you they've had 5 cut downs and 3 ports and 16 picks. And they always get Betty, who's 80 years old, and she invented the IV catheter. You know, that's the really bad history. They get 2 points for that. And then mitigators, mitigating factors would be a septic patient, a pediatric patient, a patient who's had a mastectomy and they only have one arm that can be stuck. And again, so they get, if they have some kind of mitigator, they get one point here. If they have multiple things going on, they get 2 points. So what do we do with that? We simply add those up. There's 4 things, 2 points per column. If they get 0 to 3, they're low risk. There's a high likelihood that you're going to be able to get access. Now, one of the things here is if they are 3 and you try and now you've missed, that miss becomes a mitigator. So now their score jumped from 3 to 4. And 4 and 5, the medium risk says consider using an ultrasound or calling a vascular access specialist. And again, part of the reason I wrote this way is sometimes as vascular access specialists, we get a little bit snotty about our ability to stick patients without ultrasound, and sometimes we fail. So just recognize that the patient doesn't care how you get the IV. They care that you got the IV. They don't care if you use an ultrasound or not. That's a notch in your belt. That's not a notch in their belt. So consider ultrasound and consider calling a vascular access specialist is what I would tell a non-specialist person using this scale. And then high risk, absolutely use ultrasound and have a competent vascular access specialist looking at that patient and deciding what needs to be done. So that's C-DIVA, and that is how we improve assessment and get the patient aligned and even. How do we improve peripheral access? Well, first of all, we don't treat all patients the same. So difficult IV access is a fact. I've got 65 papers in my library as of 3 months ago when I started writing this up. I've put a few more in there now, so probably 70. When there's 70 papers out there identifying difficult IV access, we don't have to argue about whether or not it exists. It exists, okay? DIVA, when recognized, must be treated appropriately. Again, there's an idea of people say, yeah, this patient's difficult. Well, what are you going to do differently than the easy patient? Nothing. I'm just going to go in and I'm just going to give it a try. Well, that's not right. That doesn't make any sense. They're difficult, so we need to bring something extra to the table. Proper peripheral access can save time and resources. Most prominently here, Lee Steer's studies that he's done at Hartford and has published shows huge savings by putting in the right line, making it last 85% of the time, and keeping the dressing intact so that the line doesn't go bad and doesn't get infected and phlebitic and thrombotic. And so that saves time and money and resources, all of our resources, especially when those resources are strained. And then we can improve by improving securement. So what are we talking about here? We really need to understand the importance of clean, dry, and intact. Now, again, as specialists, I hope that we understand this. I hope to goodness that we understand this. But we need to roll this education out throughout our facilities. All of our staff, and I'm privileged to work as a consultant to go into facilities, and I go into rooms and I look at IVs, and like I wouldn't leave that IV in a dog, let alone in a human being. And some of you love dogs, and I do too, so I'm not casting any aspersions, right? But I'm just saying, they're horrible, and they got 15 pieces of tape on them, and there's a big blood clot underneath them, and it's all bruised up and red and inflamed, and it's just horrible. Clean, dry, and intact has to mean something. We need to teach people with pictures. and they need to understand what is intact and what is not intact. 15 pieces of tape reinforcing a TSM is not an intact dressing, okay? Stabilization to prevent catheter complications. We need some more evidence on this, but there's good initial evidence that stabilization will help things last longer, and it just makes sense, right? Again, if that catheter is pistoning in the vein, it's going to set off inflammation, then that inflammation is going to lead to thrombophlebitis. And then next level securement is a way to improve securement. I started out when I was taught to put an IV in, to tear some pieces of tape that I wore on my stethoscope and that were banging around on my shirt as I was a paramedic and everywhere I was going, and to tear some of those, make this chevron thing, and then put a Band-Aid over the actual skin puncture site. Well, we don't have to do that anymore. Unfortunately, people are still doing some of those things. The first way that we can do next level securement is reinforced TSM, transparent membranes. So we have just basic transparent membrane dressings that are designed for anything, and we have some that are designed to really be reinforced and to hold an IV or a central line or a port or whatever that dressing is to hold it better. What else can we do to help out? There's glue that can help secure things, make sure that things aren't moving around, make sure that they're staying in, make sure that we're covering up where we've pierced that patient's frontline defense against infection, their skin, and make sure that an infection's not getting in. And then there's engineered stabilization devices. We have these designed for peripherals, for midlines, for central lines. Engineered stabilization is a way to make sure that we're securing things, keeping them in, making sure they're secure when we're moving patients around, that we're less likely to disrupt that line as we move the patient. All right, I'm going to just flip past this poll here in the interest of time, Judy. So let's also quickly talk about arterial access. A lot of these patients had very low SATs. They were getting blood gases, these COVID patients. And we haven't really traditionally talked about arterial access when we're talking about peripheral IVs and central lines. It's kind of been a separate topic. And so what I want to talk about is the peripheral arterial catheters, PACs. So we talk about PIVs, we need to talk about PACs. And many of them continue to be placed blindly. And there's really not a good excuse for doing that anymore. The actual technique taught for a blind stick is to stick through the artery and then pull back until you get a flash and then redirect into the artery. And then we're traumatizing two spots on that artery instead of just entering the artery as atraumatically as possible. So we really should be using ultrasound as much as possible. A lot of these are still placed in areas of flexion. And again, why? Because in the wrist is where it's shallow, it's easy to feel the pulse, it's easy to do a blind stick, but that's not the best place to put a PAC, because empirically we know that there's high failure rates. Those PACs don't last when they're placed blindly in the wrist. If we go a little bit up the arm, get away from the areas of flexion, use ultrasound, do it atraumatically, really dress it well, get an intact dressing, keep an intact dressing, we can make those things last longer and not have to come back. Again, a sick patient in the hospital, we've really kind of got two shots. So if we lose a PAC on one side and we have to go do it on the other side, is that artery going to heal before we need to use it again if our lines are only lasting for 28 hours or 32 hours or 36 hours? Probably not. And lastly, let's talk about improving central access. The first thing is that we need to recognize that all central access devices are contributors to CLABSI. I just don't even know what to do with the ongoing conversation about pull the central line and put a pick in so that we don't get dinged for CLABSI. Or we're going to pull the central line and replace it with another central line every 7 days so that it doesn't get infected. All of these things are contributors to CLABSI. Securement and care issues are bigger contributors than placement, modality, and site selection. Okay, we know that that if we follow the bundle that was first started back in 1988, if we use good sterile technique, max barrier precautions, all those things, that we can eliminate huge amounts of CLABSI. I started out in my career watching people put central lines in wearing a white lab coat and a bouffant cap and a mask and a pair of sterile gloves, no gown, a 24-inch fenestrated drape. And we know that's not the way to do it anymore. So now we don't do that stuff very often, hopefully never. But once we get that in, the securement and care issues are what's gonna, if we can keep that intact dressing, that's what's gonna keep us from getting CLABSIs as much as or more than how we place it. Removal, again, we need to, we need to remove disparities in central vascular. Let me read my own slide here. We need to use ultrasound for all central vascular access. We really, unless it's an emergency and the ultrasound's broke and all that kind of stuff, we really should be using ultrasound and trying to get optimal placement and of any central line. And that ultrasound also lets us do things that we can't do blindly. And then we also need to talk about in central lines optimal line placement using ECG technology. It's become increasingly common in Europe to use ECG technology for central lines. Now it's become quite common in the US to use it for PICs, but a lot of central lines don't get that same treatment. In Europe, they're a little bit ahead of us on that. So that's something that we can talk about. How do we get there? How do we improve that? And to me, the answer is kind of obvious. The people that are putting the PICs in that already know how to use ECG probably should be doing more central lines. And we need to expand the understanding of the evidence and the guidelines. What are we talking about there? Lines should be placed and maintained for clinical indications. We don't change out one CVC, a CVC in the neck for a CVC in the arm because we perceive it as being a lower risk. It's a stick, it's a central line, they both can have CLABSI, and sticking the patient twice just doubles the chance that you have some kind of flora get in that skin hole and set up an infection. We need to understand that needed viable CVCs can stay in indefinitely. I hear of hospitals that have a policy, we can't keep a central line in for more than 7 days. After 7 days, we have to take it out. Well, that's no different than the hospitals that are still saying we got to rotate our peripheral IV every 72 or 96 hours. There's no evidence for that. They can stay in as long as they're needed and they're viable and they're dressed and intact. The guidelines that are available, again, a lot of us in the vascular access community are familiar with this, but we need to educate other people. We need other people to that we're working with collaboratively to understand things like MAGIC, DAV Expert, KDOQI, and the CHEST guidelines. Again, unfortunately, sometimes the people making the decisions, there's a clinician who's not going to do the line, but they're writing orders and they don't understand what these guidelines are. And so we need to push that out. We need to have those conversations and make people aware of what these guidelines are. Let's talk about care and maintenance quickly, and then we're going to be out of time. 99% of life of any vascular access device. We've got to scrub the hub on every access. Probably that would help if we did a better job of using protectors on those hubs. We need to limit add-on devices like stopcocks and manifolds. We know that those increase our chances of infection. We need appropriate flushing to maintain the line. Push pause at least every shift, all of those things. Again, I've kind of beat this drum a lot, but maintaining dressing integrity. We need a care and maintenance bundle probably to help maintain standards of practice. There's some really good evidence on this. If you're not using this now in your facility, you should look at that evidence. Karen, bundles are a tried and true thing, just like tools. They set the standard that we're going to do this the same way every time, and they help improve efficiencies, and they maintain standards of practice, and they decrease complications. And then especially for central lines, but really for any vascular access device, we need to assess for complications, and we need to remove or replace when appropriate. Again, keeping a peripheral IV or central line in just in case. We don't do this as much with central lines. It's really the peripheral lines. The dressing's falling off, the thing's all red and inflamed, but I'm going to keep it in just in case because I might need it. Well, it's probably not going to work for you anyway, but and it's not going to be good for the patient, and it's just providing a chance for more infection. So those are, again, nothing revolutionary here. This is all basic stuff that we've known, but now we have a crisis that highlights how important this stuff is. And so it opens up opportunities for us to have conversations that maybe would have been much more difficult to have 3-4 months ago, but maybe now, or maybe a month or two from now, we can have those conversations about improving the way we care for patients, because this is going to happen again. This isn't over yet. We've still got to get through the summer, and we got to get through the fall, and we got to get through next year, frankly. But then 3 years, 30 years, 100 years, there's going to be another thing. And we've always got to be striving to find the best that we can do for our patients, because every adversity has a seed of an equivalent or greater benefit. And so we can focus on the adversity, or we can focus on the way that we can utilize that to improve care for our patients. And that's what I'd like to see all of us do. Thank you very much for your time.
Let's go on the care and maintenance slide. What do you mean by 99% of the vascular access device? Great question. They maybe not have listened to Dr. LeDunn speak before.
Right, yeah. That's shout out to Dr. LeDunn. 99% of the life of the vascular access device is care and maintenance. So we can do a fabulous job of putting a device in, but if people are not scrubbing the hub, if we've got a central line in ICU and they've got a big manifold on there, and it's laying in the bed, and the dressing is peeling off because the thing is up the neck and it's not secured well, then that's where the danger is for getting an infection or having a dysfunction of the line or displacement of the line. So it's just a point that we've spent in the past. We've spent a lot of time focused on the initial placement of the line, and not that that's bad, and not that we're ever going to give that up, but we also need to spend an equal amount of time focusing on what happens while the line is in, and all these things: clean, dry, and intact. Make sure that every single access is a good access, that we're scrubbing the hub, that we're not contaminating anything. That's what we mean there.
And I think the other part of it, John, is when Dr. LeDunn put together his chart, he did a survey of many people that place central lines. It takes approximately 7 to 10 minutes. I think he gave 15 minutes to place a line. Lines dwell an average of about 7 days. If you add those minutes up, the placement itself is 1% of the life of that line. So if you look at the timetable, I think that was a big part of what he was mentioning too.
Yes.
Next question for you. You're welcome. We use an approved securement device and transparent dressing. Tape on the tables and surface are not acceptable securement in our facility. I hope this practice is not seen as frequently.
Unfortunately, it is still seen. I'm still a little shocked when I go into hospitals and and I see nurses walking around with a large roll of tape on their stethoscope where it's going from room to room with them. And I still commonly go in and see torn tape on the bedside table or on the rails of the stretcher, and those, we know it takes 10 or 15 years to break some of these habits. Chevrons really kind of went out 20 years ago, so I'm a little surprised that we're still dealing with that. But we just have to patiently educate people. This is not okay, and there's a better way. There's a better way to do this. I still see people take the TSM and peel the backing off and lay the TSM down on the blanket of the bed, and that doesn't seem like a good practice to me either. But hopefully we're gonna see more hospitals like that one say this is not acceptable.
Agreed. Do you have any articles about leaving central lines in, or CVCs, remaining as long as needed versus replacing with PIC? We're getting totally exhausted with this recurring theme. I know this is a limitation with the emergent non-tunnel line coming from CDC work study group many years ago.
Yeah, again, we do need more research on that. The problem is it's really hard to research, a negation like that. You shouldn't take out the central line in favor of the PIC. Again, the education piece is, why was that central line in the first place? Is it still working? And why would we want to change it out? It's no different than saying, well, they've had an IV in their left arm for a few days. Let's put one in their right arm. Why? What sense does that make? It's a central access device. It's working. Why would we change it out? And if the answer is simply to avoid CLABSI, then switching out one central line for another doesn't avoid CLABSI. You actually increase your risk, because if the first one isn't infected, what happens if the second one, if there's something happens when the second one goes in and it gets infected? Then there's a liability there that you actually caused an infection that you could have avoided if you just left the thing alone. So I think there's a lot of rationale behind it. It's a difficult conversation. Again, I would hope that one of the ways that we can move this discussion forward is, there's, in the past, the discussion's been, we're doctors, we do central lines, you're nurses, you do PICs and IVs and stuff, so you don't step into our territory. But as we do those more, as that becomes more and more of a vascular access specialist skill away from the medical skill, then we can have that conversation more, and hopefully somebody will publish. Although it's difficult to know how to say that's not needed. Again, the complexity is sometimes maybe the patient is going to be on long-term antibiotics and they need a PIC at some point. So it's a question, do they need a PIC today? If you're putting PICs in that the PIC is staying in less than a week, where it's being used as a central line, I would track that and I would publish that. And if they're getting 2 central lines and they could have only had 1, I would publish that, because that's a tremendous waste of supply and time, and it's a waste for the patient to have to be stuck twice.
So we have a listener that says, I do not trust central lines alone if the patient is going to be admitted to the ICU or critical care unit. Always make sure I have a secondary line. So he likes it just in case. What do you agree, John? I'll weigh in as well, but I'd love to hear your.
Well, I'm waiting to find out what's going to happen. I was supposed to present at AVA this year a talk called "The Case for Just in Case," and so we'll see if that's still going to be on. I don't know how that's going to come down with the difference in format that we're having to go to. I think that on its face, the idea that I want it just because I want it and it's going to make me feel better is an extremely weak case. If you can make a clinical argument for why I think there's a greater than 50% chance that this patient is going to need more than what I can do in the central line, then it's not just in case. Then it's a clinical decision. So if you're making a clinical decision, so we just had this conversation on Facebook the other day. You know, the ICU says every patient coming from the ER has to have 2 IVs. Well, I disagree. I've admitted lots of patients to the ICU that were going to the ICU. They're going to the ICU just in case. So now we're going to have just in case squared because we're going to put in an extra line just in case because they're in the ICU just in case. You know, they've got a GI bleed, but they're stable. They've been in the ER for 6 hours. They're stable. They're not actively bleeding. They're stable. We've got one good, well-working large bore IV. They're not getting blood products. They're stable. Do they need a second IV? Probably not. That's a clinical decision, and that's different than JIC PIV.
My put is there should never be a just in case line. There should be an IO available. If you can put an IO in 7 to 10 seconds, you don't need just in case. That just in case is just in case we want to give them another infection or uninfection. So I am not an advocate for just in cases.
And I think if you track if you're putting lines in just in case, I would be willing to bet money that way beyond 50% of those lines, if they're not actively being used, I would be willing to bet that 60-70% of them are not viable if you come back later and check on them.
Okay, our next question. I have a patient that has a fistula, active fistula on the left and a right hand burn with a scar on the right. Where would you suggest a PIV for a 49-year-old?
A burn on the hand. Oh, like a fresh burn on the hand is what they're saying, Judy?
It says burn with scar.
I mean, I always, you know, for years and years and years, going way back, even before I was a nurse, when I was a paramedic, I mean, I want my IV in the middle of the forearm, away from flexion, where in a nice flat spot where I can get it secured and keep the dressing intact and all that good stuff. So that's where I always want to be. I use hand veins for, you know, for procedural things, if that's what we can quickly get for a short procedure. So I don't really want to be in the hand anytime I can get something better. And again, so that would be, that patient has 2 mitigating factors, right? So if we go back to the assessment tool, right off the bat, they've got 2 mitigating factors. If they don't have anything visible and they have very few palpable things, we're already up to 6 points, and we probably need to get an ultrasound and find the thing that's going to work for this patient. Get a really good IV in there. Since Blake's on the call, I didn't tell this story earlier, so I'll just throw it in here. When Blake and I were working together on a team in the ER, he put a 20 gauge IV in a little old lady that was getting admitted with pneumonia. She ended up staying in the hospital for 19 days. And the 20 gauge 1 3/4 inch catheter that he put in lasted her for 19 days, and it pulled out and she went home. And it's doable, and that's what we need to be striving for. But it takes good securement, good care and maintenance, good placement, all these things we've talked about.
A pediatric patient with no arms and legs as they were amputated presents to the ED for rule out appendicitis, gastro, and needs IV labs. He has an above the knee bilat and above the elbow on arms. You go to their neck. Where do you place the line? Sorry, I jumped in on you, but
yeah, that's I mean, those are exceedingly difficult patients, but those are, again, we have to develop a plan, and we can't just wade in and start jamming needles in them. Unfortunately, a patient like that is going to need high level advanced access every single time they come, right? Because all of our basic PIV skills are all about the lower arms, and in emergency in pediatrics, we can talk about lower extremities with many caveats, right? But if they have no lower arms and they have no lower extremities, we have, I mean, by definition, now we're talking about some kind of advanced access. Those are difficult cases, but yeah, you have to do. In the ER, I know the doctor says, well, I don't think this patient's sick enough to need a central line. Well, part of that is a lot of times when I was working in the ER, the only central line we had was a 7 or 8 French triple lumen central line. Well, the patient certainly doesn't need a triple lumen. So what we need something smaller that would, we just need a single lumen line that we can get some studies, determine whether or not this patient has a surgical issue, and get them taken care of. But again, that patient, as a pediatric, that patient is going to use up what vasculature they have and probably end up needing a port at some point, right?
Absolutely. Going back to your presentation, there's a question about the placing a central line and just in case scenario. So the question is, so are you saying it's okay to place a central line just in case? I think you're talking about the COVID being transferred up.
Yes. So again, and you caught me on that. The way I said that, I didn't frame that well. But just as I framed for the previous couple of questions ago, there's a huge difference between a clinical decision and let's ward off badness by doing something. One of them is scientific, and one of them is medieval. Let's hang some garlic in the room to ward off the bad spirits. That's the just in case scenario. So we're making a clinical decision that this patient presents with this and this and this, and we think there's a high likelihood that this patient is going to decompensate. And would you rather have a central line in place when their blood pressure is 100/60, or would you rather be putting it in when it's 60/40? And what's best for the patient? There is a time that you say, we think there's just a high likelihood that we're going to need this, and we're going to put it in now, even if we don't need it 5 minutes from now. Because the central line at 5 o'clock in the afternoon and the central line placed at 5 o'clock in the morning are two different things also.
Any info you can offer on the pH or osmolality of remdesivir? We've had many patients receiving it and providers asking for ultrasound guided PIVs in midlines. Is it safe for peripheral administration?
Yeah, so that question has come up. I know several people have looked for it, and I haven't seen anything. Again, the problem with pH and osmo and stuff is it also depends on how you mix it up, how you reconstitute it, and all those things. There's not a standard prepackaged remdesivir that I'm aware of that you could say, oh, this one is this. The one study that I was able to find just showed a relatively high rate. I think it was 24-26% phlebitis with remdesivir in a peripheral. So is it safe to give peripherally? Again, I don't think those questions are never completely black and white, on and off questions. If you have a great line and it's in a good vein and there's good flow and it's well secured and it's being assessed properly, there's all kinds of things that become possible. If you, I'll just tell you, I mean, when I started my career, we were given Phenergan in peripheral lines 50 times a day, every day. and we knew it wasn't really safe. What I was trained to do was to make sure that you had a really good line, and make sure you dilute it down, and don't slam it in some janky IV that's going to infiltrate, because that's going to get you in big trouble. So I'm not advocating that we go back to that. Phenergan, we've got better things, and it's not a good drug to use in peripheral IVs. So that's my caveat on remdesivir. Just be aware that it has a high phlebitis rate. And so I would want to know that I had a really good IV. I'd want to know that it had good flow around it, where it's going to, as we infuse that remdesivir, it's going to get diluted in the blood flow. And then I would want to keep a really close eye on it, which means I'd be really, really careful infusing it into something in the upper arm, some kind of extended dwell or midline or something like that, because it's going to be harder to recognize that inflammation if it sets in 2-3 days from now.
This is a great question. I can't wait to hear your input on this one, John. Your point about not taking out central lines to put in other central lines, but the question is, don't the insurance agency dictate this policy? I go to hospitals that want me to put in a midline because the patient came in with a PIC from another hospital. I'm told the insurance companies will not pay for an infected, I'm told the insurance companies will pay for an infected midline, but not infected PICs.
Yeah, well, at the end of the day, we have to make money, and money makes the world go round and all that kind of stuff. I just, again, on its face, I get really concerned with any discussion that the primary driving factor is money. I'm much more concerned about what does the patient need, what's right for the patient, and how do we make sure that that's the best thing for the patient, that it's not getting infected, that it's now, it's also concerning the way this question is framed, Judy, because this idea that we can only trust lines that go in here. We can't trust lines that go in someplace else and they come to us. So we're going to shoot a chest x-ray of every PIC that comes in to make sure it's not flipped up, even if the patient's had this PIC for 2 years at home. It just, at some point, again, those become non-scientific ways of looking at life and addressing life and the uncertainties of life. We have to assess the patient, ask what the patient needs, what's best for the patient. And the fact of the matter is, PIC lines, that the beauty of PICs and the reason that we use 5 million a year or whatever in the world is because we can send patients home and they can walk around and they can do a lot of their normal life activities. They can't go noodling for fish, as one person asked me just last week, but they can do a lot of regular activities, and some of those PICs are going to flip. But we don't need to irradiate 1,000 patients to find the one patient that their PIC somehow flipped up, and yet it still flushes good and has good blood return, and that's looking for a needle in a haystack. And if you're going to start doing that, just pull every line that comes into your hospital. Let's just CAT scan everybody from head to toe when they come in to make sure that we don't miss something, and it just becomes crazy. So I don't know. It's insurance is a weird thing. It's a weird game. A lot of it goes down to how you document stuff. And so if you document that the line came in and that it was in place for 3 months before the patient got to me, and I'm more concerned if they had the line for 3 months and they come into my facility and they end up with an infection. I'm more concerned about the fact that something bad happened in my facility that got an infection, rather than who's paying for it, right?
Should be.
Who's paying for it is low concern.
So Anton's asking, what do you think of subclavian central lines? Do other hospitals place them? I'll jump in there really quick. Subclavian lines, the only problem with those is one if they're a hemodialysis patient. If they're a kidney patient, they shouldn't get one in their subclavian. But they're generally placed blind. You chisel down the clavicle to the ipsilateral nipple, and that's how you put those in. So if they're putting them in a little bit further out, they're actually axillary lines, and they're great. They're beautiful. They lay flat on the skin. You can dress them beautifully. So they're wonderful.
Yeah, it's interesting, Judy, because again, years ago in the ER, very common practice, you know, to throw the patient down, and the doctor puts his hand down and he feels, you know, the landmarks, and he sticks that subclavian stick and stick in and out until you get a blood return and hope you don't drop the lung. And then as we started using ultrasound, we really went away from that quite heavily, and I just didn't see that very much because they're going to the neck and using ultrasound. And of course now what we're starting to see a resurgence of those axillary lines where you get away from the clavicle so that you can visualize it and you can do it with ultrasound. I think they're great if you know how to do them. I'm totally with Judy. I was just a couple months ago, I was in a hospital and I was present for a central line placement with a doctor, and ultrasound machine in the room, pushed the ultrasound machine aside, did a blind subclavian stick, and you know, when it's there and it's draped, it's kind of, I just don't understand. But yeah, I think they're great. I think they're much better as far as securement. I think most of the time it's better for being able to keep a dressing intact, as we were talking about earlier. You know, the problem in the neck is that sometimes when people are intubated, they get juicy and they get saliva flowing down their neck, and that's not a great thing to have around the center line. And so if we're out here on the shoulder, we can probably keep that cleaner. So there's a lot to like about it. Again, I've had some discussions with some of my ER doctors about that. It's more dangerous because the lung is right there. Yes, it is. But if you know what you're doing with the ultrasound machine, and if you know how to actually guide your needle and not just do an ultrasound assisted blind stick, it's really not dangerous at all if you have the skill.
Under ultrasound,
Yeah.
you can see the artery, you can see the vein, you can see the pleura. It's gorgeous down there. But so we're going to take a couple more. One of these is just support, I think. So Jay Cherie, beautiful name, by the way. Jay Cherie says, how do you suggest providing safe access when you have to deal with pushback from your boss and the doctors who don't know your recommendations? First of all, invite your boss to our webinars. Free to come. Please, please, please. John, why don't you take that one? Get your input.
You know, and I would say I was resistant for a long time in my career to getting certified. And you know, I felt my thinking was I know what I know, and I have expertise, and people that know me respect that. The nice thing about certification is it really puts it right out in front there, and it says, you know, I've actually studied for this, I know this, I'm a specialist, and I'm certified in this. And so I think that's a good step. Jayshree, unfortunately, you know, what we need to do in the broader community is we have to continue to grow this as a specialty. We need to get recognition. And again, this is what we're talking about here today. This has provided a chance for us to make a case for why this needs to be a recognized specialty. That there's certainly still room, and there will be room for generalist vascular access, but we need to really expand the ability to do specialist vascular access. And I've had conversations with doctors about KDOQI, and they don't know what we're talking about. This is a well-recognized standard that says this is how you approach vascular access for people. There was just a study I read just last week, I think Thursday or Friday, that talked about inappropriate vascular access for renal patients, and people not recognizing It doesn't do us any good if we save that 40-year-old today, and 5 years from now, that 40-year-old needs dialysis and they can't have a fistula because we put the wrong device in, and we damage their vessels. And that might be something that shortens that patient's life by years. And so we really have to, again, we have to examine the evidence, and we have to make these arguments. And we, part of that is learning how to talk, learning how to look up evidence and present evidence. It is a difficult thing. In my experience, I've had a conversation, I've presented the evidence, and people look at the evidence and say, I don't care, I don't agree with that. And what do you do with that? I don't know. You just have to keep showing the evidence and having the conversation, and advocating for what's right and what's best for your patients, really.
And last question, and folks, there's still probably 15, 20 questions there, but one of the things we've gotten on our surveys is we go too long in the Q&A. So I'm trying to keep a happy medium here. What I would like to do is afterwards, John and I will divvy up some of these questions. John, I'm giving you homework, my friend, but we'll go through these and we'll send an email out with answers to these as we can. So I have been frustrated by physicians who want to pick place in patients with ports because they don't want the nurses accessing the ports. Thoughts? My head's spinning. That's my thought. No. John?
Yeah, the one that's so memorable to me is I had a patient that came in that was a very difficult access patient. She had a port, and the patient actually, she had been influenced by her doctor. Her doctor said, don't let anybody touch this because they'll infect it. And again, to me, that conversation's already off the rails. If you're saying these oncology nurses can touch it without infecting it, but those other nurses can't touch it, how is that working?
We need to
again, not to denigrate their specialty, but accessing a port is a pretty general thing, and basically we're talking about sterile procedure, which is bedrock nursing. That's Florence Nightingale, right? So we can't say these nurses are good at sterile procedure and those people over there are dirty. Well, they shouldn't be nurses then, or they need to be re-educated and encouraged to be better with it. So yeah, that is and what I have done with those is I'm going to have a conversation with the patient. We're going to talk about what's best for the patient, what the patient is comfortable with, what the patient wants, and hopefully drive that conversation. Again, putting that's not a clinical decision. That's a just in case decision. I want you to put a different line just in case you infect the port, right? So we're back to that scenario again. Plus, is it really good? How many foreign objects can we put into the SVC? How many is safe? Well, the answer is really easy to that question, right? The safest thing is to have the least number needed. So if there's already a catheter sitting in the SVC, why do we need to put another catheter in the SVC? That doesn't seem to make sense for the patient.
What's the catheter vein ratio? It's going to increase it in the cava as well. So sure. John, there's two other questions that go together that I have to address, because one, we're working on a webinar to address them. So one is about, thanks for your answer, we want to do EJs. So EJs are a really tough line. They actually come in and do a little jig as they're coming in. So they're smaller, they're tougher, but I know a lot of these webinars, we've had questions about advancing your scope and difficulty putting the right line in. One of our questions is, I've got bilateral DVTs. Where do I go? Well, you go to the neck or the chest. And if you have to, you go to the leg, because you don't want to put it. If there's a DVT, it's kind of like trying to drive on the freeway and there's a crash in front of you. You aren't going to get where you're supposed to go. Right. But so we are working on a webinar right now for advancing practice and advancing your scope. Excited about that. So hopefully we'll have that out, announce it in the next 3 weeks, not to have the date in 3 weeks, but really working on advancing your scope so you don't have to place the rung line and you're not limited. And I know a lot of people have talked about it. You have a lot of it, and many of the questions we're talking about today too, about not getting buy-in from your physician. A lot of that is building rapport. We need to build rapport with everybody we work with. So as they start to learn your specialty, and to John's point about having board certification, that starts to build more and more rapport to where you are a collaborative team, as opposed to someone where they want to tell you what line to place. John?
Yeah, they're just delegating stuff.
Yeah.
Yeah, let me just quickly address the EJ. I have a personal history with that. As a paramedic, you know, I went to a 9-month paramedic program, and I could go out in the field, you know, right out of school. I could roll somebody's neck over, and I could start an EJ, and nobody blinked an eye. I work in the field for years. I go to nursing school. I get my nursing license. I come into the hospital, and oh my goodness, why would you ever do that? That's horrible. That's so dangerous. Oh my, you know, this is just out of bounds. You can't do that. That's so crazy. Why would you ever even think about that? And it's just such a disconnect that as a 23-year-old, very minimally trained EMT, I could do something that as a 33-year-old, highly trained nurse, I couldn't do. And
good point.
so a lot of that is just this perception that somehow jamming a needle in a vein in somebody's neck is wildly more dangerous than jamming a needle in a vein in their arm. And I don't think that that's true. I don't think that makes any sense. It doesn't hold up to any scrutiny. If we throw in now again, I'm not advocating that nurse generalists be running around putting EJs in. But I
was
think
talking about central line through the EJ, John, by the way. I wasn't talking about
the central line. Okay.
So
not just a simple.
spreading it. No, I'm sorry, my brain didn't go there.
Again, if you are an expert at using ultrasound and putting a needle into a vein, the EJ and the IJ become, I mean, it's so much easier than a pick from the standpoint that the thing tends to be 4 times bigger, 3-4 times bigger. It's so huge. And there are some caveats. We have to be aware that probably nobody's going to suck an air embolus in through their bicep, and they certainly will suck one in through their neck if we're not using the appropriate equipment and we're not doing the skill appropriately. The biggest thing that we have going for us is that the tide is running. More and more and more vascular access, non-physician vascular access teams are placing all these devices. Again, as we talked about earlier, including even large bore acute hemodialysis catheters, which are like, you know, a central line on steroids. And so there's great evidence. There's published studies out there that show that this is being done. It's being done safely. It's being done effectively, and it's really cost effective. You can pay a physician $180 an hour to stand at a bedside and do a central line, or you can pay a nurse 40, 50, 60, depending on where you are in the country, an hour to stand there and do that same line. And so I think we're going to continue to see that come on, and hopefully as more people get certified, as the recognition of vascular access as a specialty grows, and we publish these great studies, and we demonstrate our competence, it's just going to get easier and easier.
Very good. Well, John, thank you so much. It was a great presentation. BD, thank you. And stay safe out there. I appreciate each of you. Bye now.